Hi, everyone. Welcome to today's session. Let's go ahead and get started. Today, we will focus on chemo-induced peripheral neuropathy, focusing on the quality of life and treatment planning for breast cancer and other cancer patients. Today's program is generously sponsored by Athenex Oncology, and on behalf of the Foundation for Peripheral Neuropathy, I want to thank our sponsors once again for making this program possible. Before I introduce our panelists for today, I'd like to remind everyone that today's session is being recorded. The link of the recording should be emailed to you within the next day or two, and will also be permanently housed on the Foundation for Peripheral Neuropathy's website. During the session, I encourage you to ask questions through the questions feature in this platform. We will address as many questions as we're able to at the end of the program during our Q&A. I ask that you please try to keep your questions focused on the topic and broad enough so that others can benefit from the answers, since we will not have time to address personal medical questions. I will be moderating today's program. My name is Lindsay Colbert. I am the Executive Director of the Foundation for Peripheral Neuropathy. And again, I thank all of you for joining today, and I hope that you will enjoy the session. Joining with me today are our panelists. Dr. Tom Smith is an oncologist and palliative care specialist with a lifelong interest in better symptom management and improving access to high-quality, affordable care. As an oncologist, he specialized in comprehensive multidisciplinary breast cancer for 25 years. Currently, Dr. Smith is the director of the palliative medicine program at Johns Hopkins, which includes research into Scrambler therapy for chemo-induced neuropathy. Dr. Smith has been recognized in Best Doctors in America for many years and is a fellow in the American College of Physicians, the American Society of Clinical Oncology, and the American Academy of Hospice and Palliative Medicine. As a metastatic prostate cancer survivor, Dr. Smith knows all too well the experience of living and working while undergoing cancer treatment, lending an empathetic ear to his patients. Dr. Stefanie Geisler is a board-certified neurologist with a subspecialty certification in neuromuscular medicine. She received her MD from the Charité, the medical school of the Humboldt University in Berlin, Germany. She did her neurology residency and neuromuscular fellowship at the Washington University in St. Louis, where she currently works as assistant professor. She sees patients in the neuromuscular clinic and reads skin biopsies to diagnose small fiber neuropathies. Dr. Geisler developed her current interest in molecular mechanism in peripheral neuropathies, which she continues to investigate now in her own laboratory in the Department of Neurology at Washington University. In 2017, she received the Wolf Neuropathy Research Prize from the American Neurological Association for her work on molecular mechanisms of peripheral neuropathy. And lastly, Krista Nelson is trained as an oncology social worker and works in clinical and research roles within the Providence Cancer Institute and is a program manager in the Department of Compassion. This blend has allowed her to bring her clinical expertise to work with those impacted by cancer and to creating supportive infusions of compassion to caregivers within Providence Health and Services. Krista is also president-elect of the Association of Community Cancer Centers. She provides individual and group support for those affected with cancer and additionally has an expertise in facilitating online support groups. Krista also coordinates a program that focuses on the care of children who have a parent with cancer. So we have a great program set up for you. At this time, I'm pleased to welcome Dr. Smith, who will be starting the presentation today. Dr. Smith, thank you.
Thank you, Lindsay. As you said, I'm a breast cancer doctor as well as treating peripheral neuropathy. My take-home messages are easy for patients. You have to partner with a healthcare professional who will actually listen to you and work with you over time to do multiple trials of medications. There isn't one thing that fixes everybody, and it often takes 2 or 3 tries of a month or so of medication additions, subtractions, and figure out a communication strategy. If you feel like you're not getting enough time, just tell the office, hey, look, I need half an hour, I need 45 minutes, and most offices will do that for you. For providers, take this seriously. The risk of serious falls is nearly doubled at 5 years. And at the University of Rochester, large study, half the women who had it initially had it still at 5 years later. If you're going to treat with a medication, do use duloxetine or Cymbalta. Please don't start with gabapentin or pregabalin. They've both been shown in randomized clinical trials to not work very well. They probably only work in 1 in 10 people. Topical menthol might help and is completely harmless as far as I know, and be willing to be referred to or do trials of medicines. And finally, meditation or mindfulness may not shut the nerve pain down, but it helps with the brain's response to it so it doesn't ruin your day, life, and week. Yoga does the same thing. Exercise. And then if your oncologist isn't helping you, palliative care, healthcare professionals may be a good fit. So palliative care is specialized medical care. It's relief from symptoms, pain, and stress of a serious illness, whatever the diagnosis, and providing that extra layer of support. That's a long definition. At the bottom, I put mine. It's not just hospice, but moving upstream. It's expert symptom assessment and management, open and honest communication, and medically appropriate goal setting. The reason for reducing symptoms is it saves lives. This is Ethan Bosch's work at Sloan Kettering with 766 patients, half of whom got their usual care, half of whom got an iPhone, and once a week they reported their symptoms. When the nurse at the other end saw those symptoms, saw them spike, he or she would call them up, fix them over the phone, or bring them in. And that's a 6-month difference in survival for those metastatic cancer patients, or 6 people out of 100. 6 people out of 100. Now back to neuropathic pain syndromes. They're common: post-radiation pain, post-surgical pain, phantom limb pain, post-mastectomy syndrome. If you ask surgeons how common is post-mastectomy syndrome, it's less than 5%. If you ask women, it's more like 20 to 25%. Shingles can be the bane of our existence. And finally, chemotherapy-induced peripheral neuropathy is the bane of my existence as a breast cancer doctor and for many of my patients. It happens in 40 to 70% of patients. It's the most common reason we have to limit treatment. We now know that for 20 to 25% of times, it may not even show up until after your treatment, so you've already lost your opportunity to reduce the dose. And it persists, causes pain and suffering. Your fall risk is twice as high. And as I tell my patients, every time you put your foot down on the floor and it hurts, it's a reminder of your cancer and puts you right into cancer-related PTSD again. What works to prevent it? We just redid the guidelines for the American Society of Clinical Oncology. There's really nothing known to prevent it. There's one small trial of fish oil done in Iran that seemed to work. No data on whether it actually protected the cancer cells either, so don't do that. Exercise keeps it from getting a little bit worse, so that may help work. There's a new drug that I won't even try to pronounce that seems to work a little bit, but it's being tested in a much larger trial to see whether it's actually effective in doing what it's supposed to. In Japan, where patients are totally compliant with what their doctor does, putting on cooling gel slippers and gloves reduced their chemo-neuropathy from 80% down to 28% in the hands and cut it in half in their feet. That looked really exciting. Half of the patients on the right-hand side of that graph of the cold, half of them had no neuropathy at all. So that looks really exciting. But my friend Judy Pace tried to do the same study in Chicago, where people are used to the cold, so cold shouldn't bother them. But a third of the patients couldn't tolerate it at all. 6% stopped during the study. There were only 7 patients who completed the study in the questionnaires, and among those 7, they found absolutely no difference in neuropathy in either the hands or feet. So we really can't recommend that, unfortunately. Here are some things that are proven not to work. That said, if you're on them and they're working for you and you stop them and your pain gets worse, go back on them. They may help 1 out of 12 people. Glutamine, lamotrigine or Lamictal, gabapentin or Neurontin didn't work with mostly platinum-induced chemotherapy. Vitamin E does not work, and increases mortality from brain bleeding in large studies. Nortriptyline and amitriptyline rarely work. ALA may make it worse, and ALC, carnitine, in one randomized trial, the control group did better than the group getting the ALC. So it actually did make it worse. And vitamins, including vitamin B12. We're all looking, believe me, for something that works and haven't found it yet. The only drug proven to work in a randomized trial is duloxetine. Take a look at the left-hand side of the screen here, and the black is the group that got duloxetine, and they started at about 5.5, and at the end were just about 4.5. So it helped about 1 in 3 patients maybe, and reduced pain scores by about 1 point. So it's not a home run, it's maybe a bunt single, but absolutely it works, and if you can tolerate it, it's worth a try. After a washout period, they switched groups, and that group, it seemed to work even better, but again, it's a 1 to 1.5 point reduction. About 11% dropped out due to adverse effects. You always have to start at 30 milligrams, don't start at 60. And there's no data on whether it helps numbness and tingling, which can be even worse in patients. So what works? Topical agents work a little bit. Deb Barton, when she was still at Mayo Clinic, did topical baclofen, amitriptyline, or ketamine, which you have to get a compounding pharmacy to make. And she took a teaspoon, rubbed it all over her patient's hands. Then they took another teaspoon, rubbed it all over their feet. It seemed to help the hands better. It didn't cause any harm. There were no significant side effects. It seemed to help more on the hands than the feet, and we don't know whether that was because the skin is thinner here or because the hands were getting a double dose when you put it on here and then put it on your feet too. It costs you about 60 months for a month's supply, and it might help with fine motor tasks like using a pencil. The other thing that works, we think works, is topical menthol cream. And Marie Fallon's an oncologist in Edinburgh who had 2 patients report to her, you know, I started putting Dermacool, which is the UK version of menthol, Dermacool 1% menthol on my hands and feet, and it really helped my neuropathy. I'm recommending mineral ice because it's 2% menthol. It's much less expensive. You don't have to buy it on Amazon.com. Most drugstores or Walmart will have this. And it binds to some receptors on the surface of the skin that actually sends a cooling message up the spinal cord to the brain. So that's why it may actually work. You apply it twice a day to the affected areas, and her patients put it on their low back too, so it doesn't hurt to put it there. 82%, 31 out of 38, had improvements in their brief pain inventory scores. Significant change in walking, sleeping, and catastrophizing. Anybody who has had neuropathic pain knows what catastrophizing is. You wake up in the morning, your pain comes back, that day's gonna suck just like the day before it. What she hadn't anticipated but noticed was that the area of hypersensitivity was reduced in the arms from there just down to the fingers in 6 weeks. So it really does seem to have some healing properties and repairing those nerves, or helping to repair those nerves. If you've tried duloxetine and that doesn't do it, morphine or oxycodone, any good opiate plus gabapentin or pregabalin works. This is not with chemo-induced neuropathy, but with other types of neuropathy. Placebo helps a little bit, gabapentin helps a little bit, morphine does work some, as does oxycodone, and the combination is always better. You can also put morphine with nortriptyline or oxycodone with nortriptyline. Here's the baseline pain, here's the morphine, here's the nortriptyline, here's the combination. So number one disclaimer is that opioids actually do work for chemo-induced neuropathy, no matter what textbooks say, and the combination is always better. You can even take out the opioid and use gabapentin with nortriptyline for neuropathic pain. Again, not chemo-induced neuropathy, but other types of pain. And in my own experience, in my practice, this actually works. So you'd use gabapentin and nortriptyline, and the combination is always better. 2 things to look at this graph. It took the pain scores from 5 down to 2. The second is this is day 15. So you really don't have to wait 2 months to see whether a treatment works. The problem is both are sedating, both cause dry mouth. So you have to have a healthcare provider who's willing to work up the dose slowly with you. Other things that might work, well, acupuncture has a long and storied history, but probably doesn't work. When we looked at the evidence at American Society of Clinical Oncology and the evidence-based complementary and alternative medicine, all the studies had important methodologic limitations, and we concluded the same, that the evidence is insufficient to recommend acupuncture for treatment or prevention. I'll tell you a little bit about Scrambler therapy and auricular pressure. And neurobiofeedback actually looks promising. Sarah Prinsloo at MD Anderson has electrodes that go on the outside of the scalp. You look at a computer screen until you can turn it blue. And if you can do that, your pain scores seem to go down by a point or two, and it's maintained 3 months and 6 months later. It's really retraining the brain to ignore those impulses that are coming from those damaged nerves. This is what Scrambler therapy looks like. The impulse coming out of these electrodes looks like this. It's constantly shifting. That may be its big difference between TENS and ITS. TEN does not work. You try to capture the nerves in this area of skin, send that back up along the spinal cord to the brain. You have to get, most people's pain is down here, but if you biopsy the skin here and there and there and there, you'll see that the nerves are damaged pretty much all the way up to the knee. So you have to start, these are EKG electrodes, start running the signal through the skin on an area that's intact. And this person's pain went from 5 to 3, next day it had come back to 4, went down to 0, and she's still out 6 months later, able to walk again. The big problem with this is it's available at only a few centers because the reimbursement for it is so terrible. So Charles Laprinzi just published this, our results from a trial at Mayo. This is TENS. TENS did maybe a little bit with tingling and numbness. There's the tingling, here's the numbness. There's Scrambler therapy, about a 40% reduction, and pain was reduced by about 60%, often lasting for weeks or months after those 10 sessions. So it does seem to work. Again, the problem is finding it. Here's Sarah Prinsloo work with neurobiofeedback, and you can see this person trying to look at these things, solve a puzzle, turn the screen blue, and pain scores went down and stayed down all the way out to 4 months. I think that's really exciting. We've also been working with auricular point acupressure. There's almost a little body on the ear right in here. This is my ear during chemo and radiation. And these are little tiny flower seeds that look like mustard seeds or radish seeds underneath these really sticky pieces of tape. You put them on your ear, or have somebody else put them on your ear in the right spot, and you wiggle them or pulse them for 3 minutes 3 times a day, and it really does seem to help pain. So in our initial trial with 15 people, you can see that pain scores were reduced, the numbness went down, the tingling went down, and the stiffness, ability to move the hand and feet, actually improved significantly as well. Again, we're now starting to test this in a randomized clinical trial. One exciting piece about this is that same thing we saw with Scrambler therapy, when people are in a high pain state, the pro-inflammatory proteins in their blood are elevated and the anti-inflammatory proteins are down. And 4 weeks afterwards, the pro-inflammatory proteins have come down to normal and the anti-inflammatory proteins have come up to normal. This, I think, is exciting because it means that there may be some sustained relief from just fixing the proteins out in the blood. We even saw some fairly significant changes in the brain towards normalization of the pain pathways in patients who got this auricular point acupressure. So that's very exciting research. That stay tuned. Here's the data on exercise from the Rochester group. This is the numbness and tingling. Here's the control group here, and the exercise group got less. This was 45 minutes of brisk walking daily plus using a TheraBand. So you put it between your legs and stretch it in order to keep your muscles strong. It's probably stretching the skin, maybe sending a normal message up to the brain that the nerves can still work. and hot, cold in the hands and feet. Again, here's the group that didn't exercise. Here's the group that did. So if you're just starting therapy, make sure you walk, get a TheraBand, and start doing some exercises. So in conclusion, here's Lucy doing exercise. Don't ignore CIPN. It can persist and cause demoralization, depression, and doubles your risk of falls. If you're a patient, find somebody to partner with for treatment, because it's more than likely that you'll need several sequential trials of medicines to actually fix it. And please don't give up hope. Think outside the pill box: topical menthol, topical BAK gel, meditation, exercise, electroacupuncture might work, or Scrambler therapy if you can find it. I unfortunately have a waiting list of about 6 months now. And keep tuned to neurobiofeedback. Thank you very much for allowing me to speak today.
Tom, thank you so much. We really appreciate your expertise. I know there's a few questions that have come in so far. We're going to keep those questions until the end for our Q&A session. At this time, I'm pleased to pass the microphone over to Dr. Geisler. Thanks so much.
Hello, everybody. Thank you so much for joining us this morning and for the foundation to have me speak this morning. My disclosures: I'm a co-inventor on a patent for SORM1 dominant negatives, and I'm going to talk about those and the NLM Scientific Board. So I'm a neurologist. For me, the question is, peripheral neuropathy is a very common disease. It's the most common neurodegenerative disease. And also, unfortunately, a lot of people get chemotherapy, but not every pain and every symptom during chemotherapy is necessarily chemotherapy-induced neuropathy. So what makes it likely to be chemotherapy-induced neuropathy? So the symptoms should typically start during chemotherapy and usually towards the later cycles. So for patients that get bortezomib, it's typically around the 4th cycle. For patients on paclitaxel, typically more around the 9th cycle. It typically starts with sensory symptoms. So numbness, tingling, burning pain. It can cause weakness, but only of hands and feet. The symptoms should be symmetrical. So both hands at the same time and both feet at the same time. It often gets worse while chemotherapy continues, and it can worsen after chemotherapy has ended for about 3 to 5 weeks. So if it starts or gets much worse half a year after chemotherapy is ended, something else might be going on. And in many patients, the neuropathy symptoms improve after chemotherapy has ended. In many, but not all. So symptoms again, the numbness and tingling, it should start in the hands or feet. Some of my patients tell me they have a feeling as if ants are crawling underneath their feet or as if they are walking on pebbles. Burning pain, patients tell me that they have a feeling as if they are walking on hot coals. Cold allodynia, especially with oxaliplatin. So if you touch anything cold, it's painful. Hand weakness. Some patients can't hold utensils. Some patients have difficulties writing or buttoning. Foot weakness, which manifests as tripping or falling. Imbalance is a big problem. And then nerves don't only innervate our hands and feet, they also innervate our organs. So chemotherapy-induced neuropathy can also be associated with lightheadedness, fainting, constipation, and diarrhea. We are part of the Foundation for Peripheral Neuropathy Research Registry. So we wanted to see, we wanted to better characterize what the symptoms are between different chemotherapeutic drugs. And the foundation, so I made these slides last week. We had 1,984 participants, and maybe some of you are enrolled in the registry. As of this week, we are now 2,000 participants, and the age range is from 19 to 97 years old. And we have 151 patients currently who have chemotherapy-induced neuropathy. And when people talk about chemotherapy-induced neuropathy, they typically talk about pain. But if we look what symptoms patients have, they all have pain. A lot of them have pain. But when you look, almost more patients have numbness, and a significant number of patients also has weakness. And then we ask them, what is the most bothersome symptom? So here patients had to pick one symptom that bothers them most. And in purple, you see pain and patients that get bortezomib. 50% of patients name pain as the most bothersome, but numbness is also very bothersome and also imbalance. And then in blue, you see weakness. A large proportion of patients also has weakness. And then we wanted to see where is the numbness and where is the weakness. And so there, the peripheral neuropathy research registry is really great, because typically studies only look at one chemotherapeutic drug. And here we can look at different drugs and compare them to each other. And what stands out is that for platinum, patients have numbness both in hands and feet, whereas for other drugs, it's more in feet than hands. And also weakness. And you can see how for all chemotherapeutic drugs, how the weakness affects it differently. So patients with bortezomib, 20% of patients have tripping, but about 60% of patients treated with paclitaxel trip. They have decreased grip strength and also problems with fine motor tasks. There are red flags. When should you definitely see a neurologist, and because something else might be going on? Asymmetric findings. If you have symptoms in your right hand and left foot, definitely go to the neurologist, see what else is going on. Profound weakness or weakness as first symptom, and also proximal weakness. If you have weakness mainly in your thighs, a neurologist should see you. And then also if it's very rapidly progressive, if you get weak quickly. In a neurological examination, we typically find that there are no ankle reflexes anymore, but the knee reflexes are there. Patients have decreased sensation to a pin needle in a length-dependent manner, meaning they don't feel it in the feet, but then when I go up to the knee, they can feel it. And in some patients, they have weakness of fingers, wrists, or ankles. If you go to a neurologist to get to have your neuropathy characterized, we typically do EMG nerve conduction studies to evaluate large nerve fibers, laboratory testing to look for other causes of peripheral neuropathy or contributing factors. And you can also get a skin biopsy to evaluate for small nerve fiber dysfunction. Dr. Smith already talked very nicely about the treatment, so I won't spend much time on it. It's very important to know if somebody has mainly numbness, there's no treatment currently for numbness, no pharmacological treatment. So gabapentin is not going to help the numbness. For people who take gabapentin to treat numbness, consider trying to decrease it and get rid of it. Tingling and pain, as Dr. Smith said, Cymbalta, gabapentin, Lyrica does help some patients. A lot of patients who come to me are already on Cymbalta and gabapentin. Other neuropathic pain medications are Effexor. I actually personally like Effexor a lot. I have good experience with it. Nortriptyline. And I agree that combination therapy is typically necessary. There are no good data yet on CBD cream or oils for topical, but Dr. Smith just sent me a little study last week where it was shown to be effective. A problem with CBD is it's expensive. An alternative might be topical, 5% lidocaine cream, that's prescription strength. Then the TENS units or the Scrambler units, I think that's a great option. Aerobic exercise, I like stationary bicycle, aqua aerobic, walking. I don't like the treadmill just because of imbalance and the treadmill keeps going. I think there's an increased chance of injuries. And then physical and occupational therapy. I want to briefly talk because, as Tom said, we have, as Dr. Smith says, we don't have currently symptoms that can prevent chemo-induced neuropathy. I want to briefly talk about research that there are treatments on the horizon and exciting new data. So this on the left here, you can see a nerve, and this is what's sick in chemotherapy-induced neuropathies. You see these individual axons that convey the information from the periphery to your brain. For the longest time, we thought that nerves die. When you cut a nerve, it just dies because there are no nutrients anymore, like a leaf that's wilting. However, it turns out that axon degeneration, as it's called, so axon death after nerve cut, is actually an active process, and we have identified the molecule that's necessary for it. So we now know that if we cut an axon, something that's called SORM is activated and the axon degenerates. If we activate SORM in a completely normal neuron, the axon will degenerate. But if we get rid of SARM1, the axon stays intact for a really long time, even after cut. And what this looks like is here. So this is a cross-section of the nerve. These round circles are these individual axons, and this is what it looks like normally. Then we cut it in a mouse, and after 7 days, you can see all the axons are gone. However, if we delete SARM1, after 7 days, you don't even see that the axons are gone. And even after 2 weeks, which is a really long time in the mice after nerve cut, there are a lot of axons left. So this suggests that if we block SARM1, we may be able to block axon degeneration and neuropathy. Neuropathy is different from axon cut, and so we looked in a mouse model whether it really works. And as you can see in normal mice, we give vincristine, so that's a lot of you probably have vincristine. It's a typical chemotherapeutic for hematological cancers. And you can see we have a lot of axon degeneration that's shown in red. But if in mice that don't have SARM, the axons are intact and they do not degenerate. And as you know, a lot of you have pain. We can't really ask the mice whether they have pain, but we have methods to test this with like this filament series of filaments. And if mice have pain, they withdraw to this filament much earlier than before, and you can see this. And if mice don't have SARM, they don't have this pain. So excitingly, deletion of SARM also protects from bortezomib-induced neuropathy, paclitaxel-induced neuropathy, and diabetic neuropathy in mouse models. So SARM1 is an enzyme, and it destroys the metabolic factor NAD. NAD is the fuel for cells. So how can we use this for neuropathy? SARM1 inhibitors. So we developed something that blocks SARM1. We inject it. It has to be given via a lumbar puncture. Then we cut the nerve. And as you can see, normally the nerve is completely degenerated. But if we inject our dominant negative, our treatment, the axons are completely intact. And here's a quantification controller. So the opposite side that was uninjured, this is how many axons should be there. If we just give a vector, all axons are gone. But if we inhibit our SARM1, then no axons are degenerated. Eli Lilly just bought this Arm Therapeutics, which was founded after others and us discovered SARM1 for 135 million, and they are currently developing inhibitors. And we have this dominant negative, which also was just the license for it was just acquired. So that's one way that I think in the future we may be able to actually prevent chemo-induced neuropathy, because we will prevent nerve degeneration. Another option is SARM1 acts by decreasing the fuel for cells NAD. So if we can maintain NAD, this might also be very beneficial. One way to maintain NAD is to take nicotinamide riboside, Niagen, which is a vitamin B3 analog, and it's currently available in food supplement stores. And there are currently 44 clinical trials that investigate nicotinamide riboside in different neuropathies and diseases. And I wanted to point out 2 of those clinical trials are in chemotherapy-induced neuropathy at the University of Iowa. And that's all I have for you today. I want to thank the people in my lab who worked with me and my mentors. I want especially thank the Foundation for Peripheral Neuropathy, with whom we are doing really great work and who support our work, my funding sources, and you for listening. Thank you.
Dr. Geisler, thank you so much. We really appreciate your feedback, and that was very educational. And again, I know a lot of questions are coming in right now for you. We'll try to get as many as we can answered later in the session. But before we open it up for all questions, I'm pleased to pass the microphone over to Krista.
Thank you so much. I want to make sure I can move our slides forward. I just want to say thank you so much to Dr. Geisler and Dr. Smith. I think part of me in listening to all that amazing information, I was thinking, wow, that is a lot. and pretty overwhelming, and thinking about, we're talking about all the things that cause neuropathy, all the ways that we can treat it. And what I wanted to spend some time in today is focusing on those of you that are suffering with it. And I show this image today because I think whether the stress is acute or if it's chronic, or it's pain or distress, however we're feeling about it, I think how we cope with it doesn't necessarily change. And I believe that our bodies need a rest from that fight or flight mode. I think we can acknowledge all the difficulty and the suffering that you're experiencing, and we can acknowledge the beauty of how you adapt to the pain. So I just want to encourage you to take a, acknowledge all your wins and acknowledge the things that are hard right now. I wanted to start my session with talking a little bit about really, during this time, I hope that you can practice some self-compassion. Even as I cover some tactics about how to cope, this isn't a time to judge yourself, but if you can just listen and hold some curiosity to some things that may help you or that might make sense to you, and not listen with the ears of, oh, I should have done this or that. So if, for those of you that don't know really this concept of self-compassion, I think we're all always learning it. It's really using your self-talk in a way that is kind and loving, and talking to yourself as if you talk to someone who you cherish. So turning down that volume of that kind of inner critic in your head, and pay attention to the knowledge that you're doing the best that you can right now. Oops. So I wanted to I felt like it would be not appropriate to not talk about COVID a little bit, and just in the landscape of all that you're going through, and acknowledge really just the suffering that my guess is you are experiencing as well with COVID. And I think one thing I've heard from providers over and over is that they are recognizing this shared connection that they have with their patients, sort of this living with uncertainty during this time of COVID. And I just think at baseline, our community and the people that we love and our providers aren't doing well coping wise, and that's okay. And just to acknowledge that these are hard times, and really listen to your body and to your emotions, and even the community, and beginning to cope with what you're hearing or how you're feeling or the pain that you're experiencing. I think we really want to start with acknowledging the emotion on how it's impacting you. Oops, wow, I'm overzealous with my clicking. So I'm going to spend the bulk of my few minutes with you talking about coping, and I think that really starts with just listening. So I can say manage your stress, and of course that's easier said than done. I don't think it's easy, but I want to pay attention to your physical and your emotional pain that you may be experiencing right now. I think what I hear from women with breast cancer is the frustration around the suffering that they're experiencing post-treatment, or maybe into their survivorship or into their journey with their metastatic disease, is that their biggest side effect isn't from the cancer, but it's from the treatment. And sort of living, how do you revision life with this new side effect? How do you cope? So when we think about how to cope, we have to have an awareness that this is hard and that we are experiencing challenges in your quality of life, and to think about how to adapt your limitations based on pain and suffering. Be prepared that things may take a little bit longer, and that they need to happen in a modified way. So this isn't necessarily giving up your dreams or things that you want to do, but it may mean that you have to do it in a different way. So that can be a little bit of the preparing. So once you've accepted, this isn't who you are as a person, but this is a side effect that you're experiencing. The cancer isn't who you are as a person. It's a journey that you're going through, but how can you continue to live your quality of life by doing some of the tactics that Dr. Smith spoke about, or maybe even some other things that you can try? I think if you can answer yes to the following question, maybe consider getting support. It's like, could you feel better about your neuropathy? Do you feel like there's things left unturned with your neuropathy. My guess is if you're attending this webinar that you're suffering in some way. So what are things that you can do, and encourage you to get support around that? That may be with a therapist, it may be with a community of other survivors, it may be partnering with your healthcare provider. But I think the next point is really just in general, how you're coping overall is going to impact how you're coping with the neuropathy. What we know that's really important is sleep. And, you know, we could spend a whole hour talking about sleep hygiene and techniques to use with sleep to help you make sure that you are sleeping. Some of the medications that they give for neuropathy do have a side effect of sleepiness. So sometimes working with your provider around when you take those medications, but doing all those things that we know help. So moving, exercise. So I kind of call that making a wellness plan for yourself. And I think a lot of patients tell me they feel better when they're active in their care and they're engaged. So there are medications and techniques that your providers are going to take, but then there's also dealing with the emotional impact of this change and using techniques that help you cope. So finding times for connection and relaxation. Do you guys have a wellness plan for this winter? You know, we're having more limits in the way that we do connect. Although many patients, I have many virtual support groups, and we're having a great time connecting in that way. And I think patients are able to participate in ways that they weren't before. They're longing for connection and a way to talk about kind of the side effects of the treatment that they've been through. So we tend to not take great care of ourselves. And if we hear everything that we heard and maybe some of these topics in the filter of self-compassion, can you think about something that you can maybe do a little different this week? And I'm not saying don't grieve that this is hard. I know that this feels like this has happened to you because of your treatment. And I was just talking to a colleague earlier today about how hard it is, that balance of knowing this pain and suffering is a side effect of surviving your cancer. But really taking some time to just acknowledge how that feels, and also though wanting to move forward and connection with other people. And if you're finding your place in a space where you're suffering, I mean, I always encourage, I even myself say, okay, is this really serving me to stay in this place of kind of negativity? What can I do? How can I modify? How can I do the things that I love to do in a different way? So I wanted to spend just the last few minutes talking about mindfulness. And I know as Dr. Smith shared, there's a lot of evidence that shows that mindfulness does help. It does help people cope. It lessens their experience of pain, but it can feel sort of overwhelming. I think there's a lot of misnomers out there about what mindfulness is. It doesn't mean you have to have a clear mind. It's really just not holding judgment in the moment and paying attention to this exact moment. And, you know, maybe a simple way is to think of it as a mindful pause. Maybe you just sit and pause and think about your breath. So in my experience, the best way to start sort of a mindfulness practice, it can be yoga. For people who are active, sometimes running, if they do it mindfully, that is really helpful. Walking, kind of taking heed of everything around you. But I have this, my favorite website for people with cancer is called thisiskara.com. It's free. It looks like an app, but it has a lot, it never charges money. So that's why I like it. And it has a lot of different guided meditations. And that sometimes is the easiest way to start a mindful practice, is, you know, to kind of calm that racing mind, is to pause and listen to what the meditation is telling you and focus on your breath and your experience. There is one specifically for pain on that site. And so maybe if the only thing you do this week different is to listen to maybe listen to thisiskara.com's mindfulness I'm in pain session. There's also, I feel overwhelmed. That's one of my favorites too. So I think just in closing, I'll say, consider things that can help you feel better and do more of them. So if that's practicing gratitude, moving your body, trying something new, and again, try to not focus on you as a disability or you as your pain or your cancer experience, but who you are and what feels meaningful to you. Gosh, I wanted to also say really connection with others is so vital and important right now. And I would encourage you to consider even there are support groups available through the Peripheral Neuropathy Foundation. There's also many support groups virtually happening for breast cancer or metastatic breast cancer, whatever it is, whatever cancer you're dealing with. Many national groups and also at your local cancer centers have those. I think one of the biggest takeaways from the group is people really appreciate being able to connect with others who are experiencing their same side effects and not having the responsibility of feeling like they're being a burden to their family or loved ones. So again, a professionally facilitated group is a great place to come and get support. And although people love being face-to-face more, I will say the virtual platforms have really been amazing. My groups are full and the people participating really are getting a lot out of tips and sharing with each other. So my last slide is just my wish for you and a wish from one of the oncologists that I work with, daughter. It says walking by the house. They put this up, be well, take care of yourself. And I think we'll go to questions now. Thank you.
Thank you so much, Krista. That was really helpful. And yes, we do have a lot of questions coming in. We'll try our best to answer as many as we can. The first question I'm going to ask the panelists, which I believe are probably more geared more towards Tom, is on Scrambler therapy. So there's two questions. One, how do you recommend a patient locate a legitimate practitioner of Scrambler therapy in the area? Because I know there's a lot of physicians right now that don't even know what Scrambler therapy is. So how do you find a legitimate practitioner? And second, how long should a patient keep up with this treatment until realizing that it might not be working?
It's really hard to find Scrambler therapy. The best bet is to Google Scrambler therapy centers. Supposedly everyone who's trained by the two groups that sell them in the United States, supposedly everyone who purchases one goes through a training session. Not all of them have as much experience as, say, Steve D'Amato down in Florida or others. And there isn't a boards that you can take or practicum that you have to pass before you can start advertising for Scrambler therapy. So just Google Scrambler therapy centers, and you can call the person up and ask them, well, how many have you treated? How many cases of CIPN, chemo-induced peripheral neuropathy, have you treated? And if they're really defensive, oh, I don't know, or then probably look to find somebody else and ask them what their success rate is. If they say, well, I don't know, then they're probably not keeping good records. But if they say, well, it's about 50%, then that's about right. I tell my patients that if I'm not making a difference in 2 days, I will Google or email the inventor and then Steve D'Amato down in Florida and ask them if they have any specific tips. It's things that I have missed. And plus we have a working group between Mayo Clinic, MD Anderson, myself, and a couple of others that we can query if anybody's had particular success. If by the third day you haven't seen anything, chances are you're one of the 20% that the signal is simply not right for. My success with chemo-induced neuropathy has changed over the years as I've learned to go way up on the legs and start above people's knees. It has to start on normal nerve endings so that you can capture normal nerve endings without it hurting too much. I wish he could tell you there were a whole lot more centers. If you're in the military or have a military connection, Walter Reed has two machines going all the time. Camp Lejeune's Naval Hospital has 2 machines going all the time. The military has had fairly significant success with this. getting about 80 to 85% of their wounded warriors off all their opiates, which is pretty significant. But I think it's going to take another couple of randomized trials showing that that really works for insurers to start covering it. There was just another one out in head and neck cancer, which is a terrible disease, and not only does the disease cause pain, but the radiation causes a significant amount of pain, particularly with chemotherapy added to it. And it was really profoundly effective and non-toxic.
Got it.
Go ahead.
Yeah, thank you. Thank you. No, that's helpful. I didn't mean to interrupt you if you had something else to say.
I sent the BAK gel recipe, if you will,
Yes.
in. That's how I tell the pharmacist to make it. And a good compounding pharmacy can figure it out without any difficulty. And it'll cost you about $60 for a month's supply. And that'll tell you whether it's effective or not. It's not perfect, but it's not harmful either. And it did show some significant changes in people's sensitivity and their ability to do fine motor tasks in their hands.
Great. Yeah, we can definitely share that with the group after this session. So thank you so much, Dr. Smith. The next question, can you, perhaps this might be a Dr. Geisler question, can you talk more about the research that's being done with people that have CIPN? A couple of the studies and treatments mentioned in the session were focused more on prevention, but that's not terribly helpful for patients who have already been diagnosed. Do you or Dr. Smith, do you guys know anything that's going on right now?
Well, there are a lot of trials where, and have been in the past, where we basically look whether known neuropathic pain medications are effective in in chemotherapy-induced neuropathy. I think there will be studies to really see whether we can prevent the axons from breaking down. I think that's really what I'm looking forward to. I think this might make a big difference later on. Something we are also doing right now is we are trying to find biomarkers to identify patients very early on, whether they have signs of nerve breakdown before they maybe have symptoms, or can see whether their symptoms are associated with nerve breakdown. So we do biomarker studies to identify patients early.
Great, thank you. Sorry, Dr. Smith?
People can go to cancer.gov and look on the clinical trial section and type in under what you're looking for, chemotherapy-induced peripheral neuropathy, and find any active trials.
That's very great. Thank you so much. That's super helpful. Krista, could you discuss compassion fatigue? Family and friends don't seem to understand with our patients because the pain is invisible. So someone just asked if you could discuss a little bit more on that.
Well, I'm sure everyone on the call experiences the impact of other people's compassion fatigue, right? And I think the key is, because it's something that people can't see, I sometimes tell family members, it's like the world that your person is looking through, it's like they're wearing contact lenses. Maybe those contact lenses are pain lenses. And so everything they look at, the future, their future plans, everything is in the context of how is their pain going to enable or not allow them to do those activities. I think the key, number one, is to be gentle with yourself and to use I statements in talking to the people who are supporting you, and just say, you know, I really wish that I was able to do those things too. I want to share with you what I'm struggling is this pain. I know you can't see it. I'm wondering if we can even maybe come up with a word, you know, or if a way that I can gently remind you in a public setting or something. If people are kind of making promises like, oh yeah, let's go to Disneyland, you know, that might not be possible, or it may be done with modifications for someone with extreme fatigue.
Sure. Okay. Thank you. Dr. Geisler, can the nerves ever recover?
Oh yes. Oh yeah. Oh definitely. And that's why a lot of patients actually get better after chemotherapy. Nerves can regenerate. We say typically up to 2 years. Typically regeneration, it is slow. So if nerves grow back, they can grow back. If they grow back, it's like a millimeter a day. So if you have a lot of nerve damage, be patient. And yes, nerves can regrow, and also pain can decrease, and it can stop.
Good, that's good news. What are your thoughts for the entire group with respect to diet? We didn't really touch too much on diet. Have you seen specific foods or supplements that that are more helpful for a patient that just underwent chemotherapy, maybe now also has peripheral neuropathy?
Being a breast oncologist, I hear this all the time and tell people to move away from a Western diet based on red meat and fried foods and move more towards a Mediterranean style or an Eastern style diet with more vegetables, more fresh fruits, fewer processed foods, and more importantly, keep your weight stable or even reduce a few pounds from when you began. So I think it's important if you're meeting with your oncologist after treatment to say, well, what was my weight when I started, and get it back down to there, because it's clear that people who gain a lot more weight have an increased chance of recurrence, not only with breast cancer, but with other other cancers as well. I wish it was as simple as telling that you need to take 8 ounces of celery juice every day. And there are some things that do seem to help. Tart cherry juice seems to help osteoarthritis in randomized clinical trials. That's pretty significant improvements. Most of those are grown in central Michigan. And again, it's pretty harmless to do. But I couldn't find, when I looked yesterday, any evidence of tart cherries juice helping neuropathy, because it probably hasn't been studied yet. I wouldn't expect it to help, particularly with knowing what Dr. Geisler knows about how the nerves degenerate. The pathophysiology of osteoarthritis is very, very different than the nerve degeneration. So I wish it was as simple as telling people to take such and such, but it isn't. And it's not because people haven't tried, it's just because nothing is successful yet at making those nerves, preventing them from dying and then helping them to regrow. But
Yeah.
for your whole self, you need to, change your diet.
Yeah, and I want to second Dr. Smith, because it has been now shown that metabolic syndrome, meaning overweight, high blood pressure, and diabetes, can contribute to peripheral neuropathy and can even cause peripheral neuropathy. So we don't, and also it's very important, you have to control your diabetes very well, or should you have chemotherapy-induced neuropathy, because you don't want any other things that make your neuropathy worse. So weight control is really important also for the neuropathy perspective, not just the cancer perspective. And then just anecdotally, there are no data, but some of my patients tell me that they do well with turmeric. So I don't know. It helps them. So it's worth a try. If you like it, try some recipes.
I love it. Yes.
I actually took enough turmeric after chemotherapy myself when I had significant side effects that I made myself iron deficient. It's a pretty efficient iron binder. The other thing is, if you're a vegan, a complete vegan, and have been a vegan for a very long period of time, it's quite possible that your vitamin B12 stores are low. So if you develop neuropathy, make sure that your oncologist or somebody checks your vitamin B12 levels in your blood.
That's a good suggestion. Krista, did you have any thoughts on that, just in general with diet? Because I know you see a lot of patients before we wrap up.
Yeah, I think just in general, take good care of yourself and do things that help you feel better. Pain can be mitigated a lot with your mental health as well as your physical. So really paying attention to your mental health and your physical, how you feel emotionally, will also help alleviate some of that physical pain.
Great. Well, thank you all. This has been extremely educational. I wish we had more time, and especially for all of the questions that have come in, we'll try our best to formulate some answers over the course of the next few weeks to some of the ones that we weren't able to answer. But again, thank you all for participating in this session. We really appreciated it. Currently on your screen right now, for those that are watching still, is a website that I'd love to have you guys check out in addition to the Foundation for Peripheral Neuropathy's website. It's a great resource and something that we just wanted to share with you in closing. Again, thank you all for watching. We hope that you liked this webinar. There is going to be a survey that we're going to conduct at the end of the webinar. You'll be getting an email on that, and we would greatly appreciate your feedback. We'd greatly appreciate your continued support so that we can continue these educational programs. For those that continue to donate to the Foundation for Peripheral Neuropathy, thank you so much. We really value you, and we're trying to continually improve our programs and our webinars like this so that we can speak to as many of our patients as possible. And as always, we are here. So let me know. Again, my name is Lindsay Colbert. I'm the Executive Director of the Foundation. I'm here. My staff and team are here. We're here in case you need us. So feel free to send us an email, give us a call, whether it's on this topic or anything else. That's what we're here for. And again, thank you, everybody, and have a good rest of your day and week. Bye-bye.
Thank you so much. Thank you very much. Bye-bye.
Thank you.